Bismillah ar-Rahman ar-Rahim. Dear colleagues, today is the fourth part of our discussion on metabolic health. Topic for today's discussion is the metabolic liver disease we cannot ignore. We know the MASLD or metabolic dysfunction associated steatotic liver disease, which was previously called fatty liver disease, is a silent epidemic. It's a global crisis by no means. It affects nearly a third of the world's population and is the leading cause of chronic liver disease. But here is the kicker. Most cases go unnoticed. So in this episode, we shall break down real-world cases, use diagnostic flowcharts, and discuss screening, fibrosis risk, and treatment strategies. Let's dive in. Case number 1, the asymptomatic patient who needs screening. A 52-year-old male with obesity, BMI 32, type 2 diabetes, and hypertension comes in for a routine checkup. His liver enzymes are mildly elevated, ALT 45, AST 38, but he has no symptoms. Key question is, should this patient be screened for MASLD? So what should be the diagnostic flowchart? Whom to screen for MASLD? Screen if any of the following are present. Type 2 diabetes, and this is the highest risk group for MASLD. Metabolic syndrome, obesity, BMI more than 30, and unexplained elevated liver enzymes. If a patient presents you with these four scenarios, type 2 diabetes, metabolic syndrome, obesity, BMI more than 30, and unexplained elevated liver enzymes, this is the patient who should be screened for MASLD. The expert insight on this case will be that MASLD is common in diabetics, yet liver enzymes can be normal. This is a catch point. The best screening tool is ultrasound or controlled attenuation parameter on FibroScan. Case number 2, discordant fibrosis scores. What next? A 60-year-old woman with MASLD, obesity, and prediabetes is assessed for fibrosis risk. Her FIB4 score is borderline, but her FibroScan shows a liver stiffness of 8.2, which is suggestive of F2 fibrosis. So the question is, does she need a liver biopsy? What the diagnostic flow chart says, fibrosis risk stratification, 2 steps. In the first step, calculate FIB4 score. And the second step is use non-invasive imaging, that is the FibroScan or shear wave elastography. So coming to the first step, that is the calculate FIB4 score. If it is less than 1.3, it's a low risk and these patients need to be monitored. If it is between 1.3 and 2.67, it's intermediate risk and needs further testing. But if it is more than 2.67, it's a high risk and this patient should be referred for hepatology evaluation. So the first step, stratifies the patients into three groups: low risk, intermediate risk, and high risk. Low risk are those where the FIB4 value is less than 1.3. High risk are those where the risk is more than 2.67, and these patients should be referred for hepatology evaluation. And the intermediate risk is those when the FIB4 score is between 1.3 to 2.67. Sorry. The second step is use non-invasive imaging. If the fibroscan is more than 8, fibrosis is likely present. But if discordant results, consider biopsy for confirmation. Among the non-invasive diagnostics, which test and when should it be used? FIB4 is best for initial risk stratification in the primary care use. Fibroscan measures liver stiffness and fat content by CAP score. MRI PDFF is the most accurate for hepatic fat quantification, but it's costly and not widely available. In case of discordant fibrosis scores, the key learning points is that FIB4 is the first, then fibroscan if needed. MRI PDFF for research are unclear cases. The expert insight on this case will be that we don't biopsy everyone anymore. But when FIB4 and fibroscan do not match, biopsy helps differentiate MASLD from autoimmune or metabolic liver diseases like Wilson's or hemochromatosis or others. Case number 3, MASLD versus other liver diseases, a diagnostic dilemma. A 45-year-old male with MASLD risk factors, that is obesity, hypertension, has ALT 80, AST 70, and a liver stiffness of 10.5 kilopascal. However, his ANA is positive and IgG is also elevated. So the key question is this just MASLD or something more? The diagnostic flowchart for MASLD or any other liver disease, red flags, which suggests an alternative diagnosis like elevated IgG, positive ANA, or smooth muscle antibodies. They may indicate autoimmune hepatitis. High ferritin transferrin saturation more than 45% will indicate hemochromatosis. Low ceruloplasmin and neurosymptoms will indicate Wilson's disease. And hepatitis B and hepatitis C serologies being positive may indicate towards coexistence of viral hepatitis B or hepatitis C. So the expert insight in this case, MASLD is a diagnosis of exclusion. If fibrosis risk is high or autoimmune markers are positive, we must think beyond metabolic liver disease. Case number 4, the MASLD patient who struggles with weight loss. A 48-year-old woman with MASLD and type 2 diabetes tries diet and exercise, but loses only 3% of her body weight over 6 months. She asks about medications. Key question is, what pharmacologic options are available? Treatment algorithm for MASLD and MASH. Lifestyle first. Aim for more than 7% weight loss, which improves MASH and fibrosis. Pharmacological options for high-risk MASLD or MASH are GLP-1 receptor agonists, that is semaglutide. It leads to weight loss plus liver benefits. Then the resmetirom, that is the thyroid hormone receptor beta selective agonist. It is effective in MASH with F2 and F3 fibrosis. In pioglitazone for diabetics with biopsy-proven MASH. And vitamin E in non-diabetic MASH patients, but it's still controversial. So the expert insight on this case is that GLP-1 receptor agonists like semaglutide are game changers in the MASLD treatment. They help both weight loss and liver histology improvement. The thyroid hormone receptor beta selective agonist, that is resmetirom, is effective in MASH and F2, F3 fibrosis. So the stump the expert rapid fire MASLD cases. I'll share with you cases and you try to diagnose them early. Case number 1, a 39-year-old with lean MASLD, BMI 24, but metabolic syndrome. How do we approach him differently? Answer is metabolically obese normal weight patients are at high risk. Focus on insulin resistance and visceral fat reduction. Case number 2, a 55-year-old with cirrhosis due to MASH. Does he need HCC screening? Answer is absolutely. All cirrhotic MASLD patients need biannual ultrasound plus alpha-fetoprotein for HCC surveillance. Case number 3, a 62-year-old with MASLD and worsening albumin, that is 2.8 gram per deciliter, and platelets 110,000. What's the next step? This suggests progressive fibrosis or portal hypertension. Refer for endoscopy to screen for varices. So take-home messages from today's discussion is screen high-risk patients, that is type 2 diabetes, obesity, and those with metabolic syndrome for MASLD. Use non-invasive fibrosis scores, FIB4 and FibroScan to guide management. Weight loss is first-line therapy. THR beta selective agonist resmetirom and GLP-1 receptor agonist semaglutide are the new therapeutic options. In high-risk patients, FIB4 more than 2.67 or cirrhosis need hepatology referral. MASLD is not just a liver disease. It's a metabolic disorder. The earlier we intervene, the better the outcomes are. So question for you, how do you approach MASLD in your practice? Drop it in the comments and we will continue the discussion on. So let's continue the conversation. Coming up next is the gut-liver axis, microbiome, metabolism, and inflammation. Subscribe and turn on notifications to receive more episodes automatically into your YouTube channel. Let's change the way we approach metabolic medicine. Thank you very much. See you in the next episode on gut-liver axis, microbiome, metabolism, and inflammation. Take care. Khuda Hafiz.